Those of you who have read the email for today's session, i.e., that everyone who is joining now knows this is a break from the Thursday tradition of discussing with a junior team member because that's what the Thursday format is. But I assure you, it is not a break from that format whatsoever. Except today, for the first time, I think I'm the junior team member. Very, very excited to discuss with my attending Professor Kirtan Patolia. So, Kirtan, maybe you should do the honors and the introduction in the role of the senior facilitator here.
No, I must say, there are some relationships which in life which never change. So this is one of those things that I imagine even if my hair turns gray one day, I will still be calling Ravi that, hey, Ravi, what do you think about my discussion? How should I improve? Do you think I could have said this? Like, I will always be asking for the tips and insights, right? So Ravi is like our ultimate teacher, right? So thank you so much, Ravi, for giving this opportunity. I know that this slot, Thursday slot, is like very precious. It comes only once in a while. So even if you sign up, by mistake, Ravi will tell you that, hey, Kirtan, it's not time yet. Please wait. So I think I had to wait for 6 months or more to get this spot. So I'm like very grateful that I'm getting this chance. And always like when I discuss with Ravi, I get like this very minute insights as to like how to tailor my discussion, how to make sure that the learning is optimized and we don't go haywire while discussing the case. So looking forward to it. And I'm like super excited today because like Fahad also, and again, this time also the case review committee told me that Fahad's case is very good and he has been waiting for a while to present to us.
Oh,
So I hope that we can do justice to this and we can optimize the learning from it. How are things with you today, Fahad?
very good. Yeah. Today's been a wonderful day. I just so honestly, what I feel every Thursday is just that I pinch myself because none of you, of course, by invention of this, were around before all this project started to work, and so I remind myself, wait, hold on, I remember. And I start to go down memory lane. I remember when I first came across Kirtan, and actually the first impression I had of Kirtan, the first ever one, was when I was solving human DX cases. If you are aware of human DX, it has a really cool app that has frequent cases. And I saw this guy named Kirtan Patolia who had 10x more case solves than anybody else in the world. And I'm like, who is this guy? And now, many years later, to develop such a strong friendship with him is wonderful. In fact, our friendship is so strong. I have no qualms telling him, "Hey, Kirtan, I have to kick you off Thursday. We have to give you have to give room for other people." Um, I wouldn't dare do that with anybody else, but I've gotten to know Kirtan so well that I'm really excited for today, Kirtan. In fact, I think we should be really authentic to your facilitation skills and just alternate and go back and forth as opposed to the typical model. And yeah, a big shout out to the two people who are making it happen, our beloved Aaron and Jillian, who have become legends, I might say, in this space. So maybe we can hand the mic to Aaron and then Jillian, and then hear a little bit from Fahad before we jump in.
Hey everyone, I'm Aaron. I'm here doing teaching points today, and I'm excited for Fahad's case.
Hi everyone, I'm Jillian. I'm doing scribing today. Excited to hear the discussion and the case, of course.
Hello, guys. I'm Fahad, and I'm very excited to present this case to two of the legendary legends in clinical reasoning here. So I hope this will be a VMR to be remembered.
Amazing. Well, thank you all for the folks on YouTube. We did it in 5 minutes. Congratulations. All right, Fahad, whenever you're ready, let's take it away.
Yes, so I'm going to just start with the presenting complaint for now. So this is a case of a 58-year-old female who presented with complaints of progressive breathlessness and diffuse bilateral limb swelling for the past 3 months. So take it away.
Go for it, Kirtan, please.
Perfect. So looks like always in CP Solos, whenever we are starting with a case, if you look at the whiteboards of last like 1 year, you will see that the chief complaint would be shortness of breath and lower extremity swelling in like at least 10 of them. And if you look at the final diagnosis of all of them will be different. This kind of highlights, right, that how medicine is so complicated sometimes that the same set of symptoms, depending on what host it is, depending on over what time frame it is evolving, can end up in widely disparate ways, right? So whenever you are dealing with a problem, as I always say in all of my discussions, right, that you have to understand the problem very well, that when we use the word progressive breathlessness, we need to characterize it further. That is it the fact that the patient was initially short of breath only on heavy exertion, then it progressively got worse to the point that even light exertion or like activities of daily living became impossible, and then finally the shortness of breath is so bad that it is at the rest as well, right? And even when we use the word shortness of breath at rest, there is a further way to refine it. That I have sometimes seen people that who are so short of breath that they are even afraid of eating or afraid of speaking, which is just another level of shortness of breath, right? And which speaks to the urgency of what you need to do right in the moment, figuring out if the airways are fine or not, right? So this is one of those things that we want to characterize better, that how the shortness of breath has evolved over the last few months. Same is true for the lower extremity swelling, that often the reflex is that when you see the shortness of breath and swelling, your mind gets diverted to the cardiovascular system and congestion proximally, which is causing the swelling in the legs. And this might be true at least 80% of the time, as the entirely the sole process in the cardiovascular system causing lower extremity swelling, or at least the contributing factor in the cardiovascular system, right? But more often than not, it also happens that maybe there are dual process going on, that of course there is something in your thorax which is contributing to this lower extremity swelling, but maybe there is something else in your abdomen or maybe in the localized vasculature in the lower extremity which is contributing to the lower extremity swelling. So again, the temporality of symptoms will be important, that when did the swelling begin? Because if someone says that swelling began, let's say maybe a week before the shortness of breath began, then suddenly you start wondering that is it appropriate to attribute everything to the cardiovascular system, or is something else at play, right? And similarly, what if there is kind of discordance between the degree of these two symptoms, that maybe shortness of breath is very eye catching, but when you go and examine the patient and the swelling is like barely ever present, then you start wondering that is it even really a swelling? Is it a problem that I need to solve, or should I just focus on the chest? So that's why characterizing both the symptoms, their intensity, their duration, will be important to guide our further differences. What do you think, Ravi?
I absolutely sorry. I had to step away, but I was hearing everything. I have nothing to add. I think teaching us that the connection between these two things is strong, but imperfect, and that we have a lot of work left to do, I think is very, very wise. So let's go ahead and do that work.
All right, so I'm going to jump into aliquot 2. So the breathlessness was in series in onset, and it showed rapid progression from New York Heart Association class 1 to class 4 during this period of 3 months. It was associated with orthopnea and paroxysmal nocturnal dyspnea. There was no history of chest pain, palpitation, syncope, or fatigue prior to this episode. Simultaneously, she also developed painless symmetrical swelling of both her upper limbs and lower limbs. The swelling was non-tender and it gradually became more pronounced. There was no history of decreased urine output, no history of fever, trauma, and there were no constitutional symptoms such as weight loss or appetite changes. I'm going to give you a bit of the past medical history, which was very notable as she was a diagnosed case of bipolar affective disorder for the past 30 years, for which she had been on lithium, escitalopram, and olanzapine. She had also been diagnosed with hypothyroidism about an year ago, and her hypothyroidism was considered to be a complication of long-term lithium use, as she used lithium for the past 30 years. And for this, she is on regular L-thyroxine therapy. Her personal history, family history, and review systems were completely unremarkable. I'm going to give you just a bit of the initial examination findings as well. The patient was conscious, oriented to time, place, and person. She was not dyspneic at rest. Her vitals revealed that she had an irregularly irregular pulse with a variable volume and a rate of 80 beats per minute. Her blood pressure was 110/70. Her respiratory rate was 16, and she was febrile at the time of examination. And I'll stop here.
Yeah, Kirtan, maybe I think Fahad, you might have to repeat some of the vital signs. I think Aaron's fingers are very, very fast, but I think unable to keep up with some of the information. Oh, sorry, Jillian's fingers are very, very fast. My apologies. I'm still waking up, I think. Kirtan, maybe what I can do is just sort of study what the case for the heart is, and the counter arguments to the heart, and then I'm curious what other progress you can make with the other information we have. And truth is that the predictive value of orthopnea and paroxysmal nocturnal dyspnea for central venous hypertension, namely hypertension, elevated filling pressures in the heart, is very high. So once you hear those things, it's hard not to translate those things into concerns that the patient's central filling pressures are also elevated, which helps you make progress towards the issue being congestive heart failure. And then when you hear there's edema, I think as we just mentioned, the probability goes up, but there is a decent counter argument to that, and the fact that her upper limbs are also swollen, it gives us some pause. Now, why is that the case? The amount of swelling in heart failure is purely related to how much above baseline is the venous pressure elevated compared to the absorptive capacity of that part of the body. So if you're going to swell from heart failure, the pressure to push fluid out increases the further and further you are from the heart. So your toe pressures in the venous space are the highest. And so this is why um, the lower limb edema is most likely to occur in that situation. Now, why the toe? The toe also because of the effects of gravity. Part of the reason why the toe pressures are highest is there's the highest amount of gravitational forces to overcome to be able to go back to the heart. The other thing that helps mitigate fluid leak into the interstitium is the counteracting effects of the lymphatic system and the venous pump. So the more and more and more you use the limb, the more and more fluid is resorbed back into the heart. And for those two reasons, upper extremity edema in patients with heart failure is less likely because motion of the arms and the use of the venous pump of arms is much more common. We use our hands literally all the time, in stark contrast to when our legs are moving physically with walking. The other thing is that the pressures required to drain the limbs are much, much, much less. And sometimes gravity alone can drain the limbs. So when you have upper extremity edema, you might be dealing with heart failure with a twist, meaning that the limbs, the upper extremities, just like the legs, are in a gravitationally dependent position. So say the patient is in the prone position or reclining most of the time, in which case the pressures to dissipate are equal across all limbs. But it also opens the door for an alternate mechanism of edema that is independent of venous hypertension and its battle with gravity. So this is the longest way of saying to emphasize that the mechanism of edema in heart failure is through venous hypertension, and the degree of venous hypertension is essentially proportional to the amount of fighting the body has to do against gravity. The limbs have less fighting to do against gravity and have more motion to push the fluid back. So when you see edema in the upper limbs, you really should question the diagnosis of heart failure. Now, it might be an unusual form of heart failure, but it also might be that the edema is independent of venous hypertension. So there's a little bit of a tension created here. And I think that tension has us moving towards the heart because of the orthopnea, the PND, the irregular rhythm that is perceived on exam. But I think doing so with either curiosity as to the mechanism of the heart failure, curiosity as to the mechanism of the way the patient exists in the world with gravity, or importantly, a keen eye to an alternative mechanism that is either contributing additional edema or mimicking heart failure in a very interesting way. All right, Mike, to you, Kirtan.
Perfect. No, I agree with Rabih that clarifying the mechanism is important because if you remember in the first report, we said that we are not sure if all this constellation of symptoms can be localized to the cardiovascular system or something in the thorax, right? So we have to be broad enough that maybe the process is not necessarily just the heart failure, but something else in the thorax. And as Ravi was saying, that maybe apart from the venous hypertension, which solely may not be the dominant factor to cause such constellation of symptoms. Maybe there is something else going on. What if we come to know that this patient's albumin is like 2, and maybe that is one of the reasons why this is going on? And how can you affect your lymphatics in a way that you end up getting swelling in the arms? So think about the most classic scenario in which you hear about someone presenting with disproportionate arm and upper body swelling, like arm or the face swelling. Then we always think about the superior vena cava syndrome, right? So The point being that in the mediastinum, your superior vena cava drains, and superior vena cava brings everything from the upper part of your body, right, including your head and the arm. And in the superior vena cava, also your thoracic duct is draining. And remember, the thoracic duct is actually carrying the lymphatics of the entirety of your body, right? So anything which impacts the thoracic duct at the level of your mediastinum, it's bound to cause lymphatic dysfunction in entirety of the body, and it can end up causing swelling and can compound the swelling caused by venous pressures, right? So, and this suspicion is even heightened more because when we hear this irregular rhythm, but with variable volume, right? Now, of course, we will get an EKG to clarify what kind of rhythm this is. Are we seeing any other evidence of pericardial pathology on EKG? But when you hear the word variable volume, it means that with each and every beat, the heart is not able to generate an equivalent amount of force, which points to two facts. Firstly, maybe there is something impeding the ability of heart to pump the volume, and secondly, there is some kind of dyssynchrony because every beat should be the same, either it's low or high. But why there is variable volume, which again raises the suspicion that, hey, is something wrong with the pericardium which I'm not able to capture yet, right? And the reason why I mention the pericardial space as one of the potential pathologic site is further because of the fact that if you think about all the pathologies which can affect your mediastinum as such, then what are the big picture takeaway which we have to remember? That is there a mass lesion there which we haven't identified? Is there a big mediastinal lymphadenopathy there? Is there something fibrosing in the mediastinum? And is there a lymphadenopathy which is somehow impacting the vasculature there? And maybe is the disproportionate involvement of superior vena cava, which is why you are getting all this swelling, right? And the same process has ability to affect your pericardial space as well. Be it an infectious process, be it a malignant process, all of them can rapidly involve the pericardial space, including pericardial effusion, which can impact the volume which your cardiac like cycle is generating, and maybe the amplitude is varying as well, right? So that is where my mind is right now. That again, to clarify the history a little bit more, maybe go back to the bedside and ask the questions that has there any kind of B symptoms which we have missed? Maybe patient has lost some weight. Maybe that can cast a clue as to what is going on in your mediastinum, right? Another point which I wanted to mention was that let's say if the pericardial pathology is not implicated, then how would we explain this abnormal rhythm, right? Now, there is something eye-catching in the history, right? That there is thyroid dysfunction, there is lithium, but we need to first establish that when this person is taking levothyroxine, whether it is appropriate or not. And maybe if the person's TSH, T4, everything is looking fine, then we can explore further that this irregular rhythm is not just stemming from thyroid dysfunction, but maybe something deeper. So what if this person actually has cardiomyopathy, right? So like Rabih was hinting towards certain unique forms of cardiac dysfunction, which might present with upper extremity involvement as well, right? So not saying that this entity can do that, but the point is that we need to also understand that if the heart is on the hook, then why the myocardium is not functioning well? Is this some kind of infiltrative cardiomyopathy which is giving rise to the irregular rhythm and also affecting the contractility in a way that you are getting such kind of swelling? So that is where I will gear my cognitive energy towards in the next episodes, that clarifying the rhythm, clarifying what could be going on in the thorax, understanding what is going on in the wall of the heart, and then maybe we can make more progress. What do you think?
Yeah, I'm right. No, I think you're picking up on a lot of really subtle and getting so much extra juice out of this data. I think if you're a person beginning your journey in these states, I think what you should take away from Kirtan is that it is unusual to have every beat be producing a variable cardiac output. You can learn to study what that means. Um, it is unusual to have edema in the upper extremities in a patient with heart failure. You learn to study what that means. And I think um, yeah, I would put those two things as the two really interesting clues that separate this patient from almost every other patient we see. So I'm excited to study those things with you, Kirtan, to see where they take us.
Before I go into the next aliquot, I want to emphasize how epic this discussion is so far. So on that note, I'm just going to share the ECG of that patient. Yeah, is it visible? Yes, go ahead.
I think it is visible, but maybe not so visible. But that maybe that is something Kirtan can shed light on. Might to you, Kirtan.
Yeah, so Fahid caught me at my weak point. Everyone knows that I'm not a big fan of
Yes.
EKGs. Uh,
Kirtan, can I
but
interrupt you real quickly? One moment, if it's okay.
yes, yeah,
I want the
please.
whole world to know one thing about Kirtan. I did a rapid fire about a fragility, a tibial plateau fracture. And I was wondering, why is Kirtan not joining the breakout rooms? He usually is the first person to join the breakout rooms. And I learned that Kirtan does not like orthopedics and fractures very much. So Kirtan, I think this is not your weak point. I think your weak point is X-rays of fractures. I'm sure you'll do a great job with the CKG.
Yeah, you're right. This is better than fractures at least. So, from what I can say, that the Fahad's examination was spot on, that we can say that this rhythm is not regular. You can see that the QRS complexes are sparsed apart at very variable intervals. So it's hard to even make that what would be the rate of this person, right? But if anything, looks like it's on the lower side rather than on the higher side. The other thing is, which is very striking, is that amplitude of each QRS complex is markedly dampened, almost as if it's non-existent. And since it is so small, it's even hard to make sense of whether the amplitude of each of those QRS complexes are uniform or variable. But like just from a bird's eye view, it looks like that maybe there is some variability, that maybe even though the QRS complexes are very small, not all of them are of the equivalent amplitude. So apart from that, like, am I seeing any other like sneaky ST segment pathologies or T wave inversions? Nothing which I could make away right now, and maybe Rabi can correct me. But based on this, what we can interpret is that whenever you see the amplitude is low, you know that there is some kind of abnormal substance situated between the myocardium and your electrode, which is not allowing the signals to be transmitted, and that is why the amplitude is of the lower size. So for example, the most common scenario being someone has like the massive pneumothorax, maybe patient is too obese, right? That is one of the reasons why the amplitude could be low. But if you don't have those factors going on, and unless you are extremes of those spectrum, you should always wonder that is there something in the myocardial space itself, like in the myocardial wall or in the pericardial space, which is impeding the transmission. So must not, I mean, if you miss someone having like COPD for like few minutes, it's not going to harm them. But if you miss someone having massive pericardial effusion as the cause of low QRS, then you are running into the big trouble. So rather than attributing all of this to like obesity or something like that, first try to figure out that can they have a massive pericardial effusion, and do I need to intervene right now before patient goes into cardiac arrest? That is first priority. And if you exhaust that possibility, then you start wondering that can there be something in the myocardium which is infiltrating, which is not supposed to be there, and which is how your signals are low, right? And this is especially even more important when thyroid is involved in your equation, right? So that's what I would say. And so far, the patient's blood pressure is fine, but you should not be, how to say, falsely reassured by that. So many people with pericardial effusion, even of moderate to severe size, have normal vitals on presentation, but all it takes is 5 minutes and any kind of hemodynamic insult for them to go down the wrong way, right? So I would be very concerned when I see this EKG because of the irregular rhythm, very low amplitude, and varying amplitudes. And I would have my antenna up to try to get the cardiology service involved, get a bedside focus, and assess what needs to be done right now before we move the diagnostic train further. What do you think, Ravi?
Yeah, Kirtan, it's amazing. I mean, I can't imagine people with 4 years of direct clinical experience getting the juice as much juice out of the CKG as you can. I'm right there with you. I think if I were given this EKG and in isolation, I think it's an interesting exercise to ask what progress you can make. And the first thing you're trying to receive with this EKG, if you just get it in isolation, is this actually a clue to the heart being a problem, or is it extracardiac? And I think the patient's BMI would be something I would immediately look for. And if I see that the patient's BMI is over 30 or 35, immediately I now know that this EKG may not be as helpful as it was just before that. And the value of an EKG in a patient without adipose tissue interfering with the signals through the roof. The next thing I would see is, before I get so excited about this powerful diagnostic tool to understand if the signal is being dampened by something else, and then I would look to see, is the patient barrel chested, suggesting of COPD, or you can even maybe whip out a stethoscope and see if there's a pleural disease that is in your way. And I don't think there is reason to suspect that there's anything in the way with the data we have so far, especially when we know at the same time that the patient's not just experiencing, now we're layering in information from the patient. We know the patient's actually experiencing something with their heart. And so I'm studying this, and I now know either she has no cardiac muscle at all, massive, horrific end-stage cardiomyopathy, which is usually in people who've had the diagnosis for 20, 30 years. So I think that's off the table. Or that she has muscle, but the signal isn't making it to Fahad's eyes. And so a very simple question is there impedance or not? And I think there's no reason to think that there's signal impedance. Um, and so um, now we're wondering, is it not making it outside of the heart at all because there's diffuse myocardial infiltration or a process in the pericardium? And it's a stretch to try to make an educated guess as to which one is happening. But if you would just apply some rules of thumb, I think that the fact that she has concomitant conduction system issues, both with her QRS and her rate, if you're trying to pick myocardium or pericardium, just as an educated guess, I think I would start to move towards the myocardium because there's concomitant conduction system disease. Of course, there is very easily the possibility that a systemic issue is affecting both her pericardium and her conduction system at the same time, such as hypothyroidism. Um, but that rule of thumb would have me going towards the myocardium. And another thing pushing me towards the myocardium is the idea that the overlap between pericardial hypertension and upper extremity edema. And the interesting thing about pericardial hypertension is pericardial disease starts to impact your arterial forward flow well before it impacts your venous return. And the reasons for that actually have been the subject of many academy sessions in the past, where we talk about obstructive heart disease versus non-obstructive heart disease. So I'm studying here and trying to say, what will the POCUS show? Will it show me a pericardial effusion? Or will it show me diffuse myocardial thickening? And I am definitely 60-40 between the two. The question is, which one is 60 and which one is 40? And I would say that the concomitant conduction system disease, along with the fact that she has upper extremity edema, which implicates a significant amount of venous hypertension, has me leaning more to a myocardial issue than a pericardial issue. But this intellectual exercise, thankfully, is a fun one to try to study clues to each disease. But as you said, I think will be rapidly clarified with the POCUS. But I'm really curious what your reflex is. Do you think your reflex is myocardial or pericardial?
So, Ravi, I would go with the easy way, and I would say that maybe both of them are involved to some extent, probably because of like the amplitude itself being like this much swayed. Worry that maybe there are both processes at the play, and we will focus will clarify that which one of them is sinister enough to be intervened upon first. Yeah.
Fascinating. That's a great, very smart answer. Both. I'm sitting here struggling which one. That's often the case. It's often the case, you're right. When you're struggling between two possibilities, I think the most common answer is actually is both of them. Wonderful. All right, Fahad, mic to you.
The official read of that ECG. Just a second.
Yeah, sure, Fahad. You can give us the official read. Thank you.
Here you go. So the read was that he had irregularly regular rhythm with a ventricular rate of around 80 per minute. The low voltage QRS complexes were noted. P waves were not distinctly visible, and sinus pauses were observed. Additionally, multiple premature ventricular complexes were present, as you can see in the left side of the electrocardiogram. So I just continue with Eliquad 4 and give you the rest of the exam and let you guys discuss. So the rest of the exam is on head-to-toe examination, which revealed that she had bilateral pitting edema in both upper limbs and lower limbs. There was no pallor, no icterus, no cyanosis or any lymphadenopathy. Her cardiovascular system examination was within normal limit, except for the fact that she had irregular rhythm. There was no jugular venous distension. There was no added sounds or pericardial disease. Respiratory system examination was also revealed that she had normal vesicular breath sounds with fine bilateral basal crepitations on auscultation. There was no other added sounds. Her gastrointestinal system examination revealed was unremarkable, except for the presence of shifting dullness pointing towards ascites in the patient. There was no organomegaly or tenderness. The nervous system examination was within normal limits with no focal neurological deficit. And I'll stop here.
Um, I think I've lost track of who's up is because this has been such a fun dance, but I suspect it's me. Yeah, I'm very intrigued by the physical exam. I think we've confirmed the presence of upper extremity and lower extremity edema, and we've added another place where there is fluid, and that's in the belly. And so now I think our problem has been amplified. The question is what to do with the fact that her cardiovascular exam is otherwise normal, and most importantly, that there is no jugular venous distension. And I think if there is truly is no jugular venous distension, that means there is no heart failure. And so the question is, how accurate is that finding? And I think if you look even at cardiologists' ability to agree on whether there's JVD or not, there's such a large interprovider variability that now what I'm doing is I'm like, you know what? There were clues, as we mentioned before, that this might not be the heart, but the case for the heart is so strong, and we know for the fact that the heart itself is unhappy given the EKG findings. So I would proceed with caution and say, yeah, I don't see that the neck is distended. Maybe that's something wrong with my eyes, or maybe there's a powerful clue that something else is going on. What do you think, Kirtan?
You are right, Ravi, that like we cannot put all our money on the fact that JVD is normal, so things are off the hook. Maybe it's not measured in the conclusive way. Maybe there were errors there. And similarly, not hearing pericardial knock doesn't rule out many things because we know that you classically hear pericardial knock when both the visceral and parietal pericardium are still in contact and there is some kind of friction between them. But once the effusion is significant enough that both those layers are separated apart, you may not hear the pericardial knock, right? So that kind of highlights the limitation of the physical examination which you can get. And again, the fact that there is profound pitting edema in the upper extremities further adds to the suspicion that something is wrong with the compliance of your ventricles, right? So like as you were saying that, is there a unique form of restrictive cardiomyopathy or is there a constrictive pericardial disease which we haven't identified, right? And another point, since now we have reached that point that we can dwell deep on this rhythm itself, that we know for sure that this is the atrial fibrillation with rapid ventricular response, or I should say with irregular response, which was confirmed on the EKG. So the question becomes that what should we make of this AFib? Should we employ our cognitive energy on figuring out where this AFib is coming from, or just first try to understand the problem in the heart, which might be causing AFib? But just for the academic sake, we could at least have a bird's eye view of AFib, right? So when you see the AFib, the first thing you should try to figure out is that is it coming from something outside the heart, right? Is there something in your blood which is affecting the electrical system? So we often think about that. Could there be something toxic in the blood, like maybe some drugs of abuse, maybe some kind of chemical substance which is affecting the way atria is repolarizing, right? And thyroid certainly takes the crown for that. Like we know that thyroid dysfunction in various forms can affect your heart. So in this case, as we were saying initially, that we definitely need to establish that what's the thyroid status of this person. And ideally both TSH and T4, because we know that the half-life of all of them are variable. And there are people who might have normal T4, but the TSH is kind of pretty weird. And maybe the TSH itself has a direct effect on myocardium, even if free T4 levels are normal. So I would say that in such scenarios, whenever you are in dilemma, and it's such a low-hanging fruit and very easy test, you should get both TSH and T4 to make sure that you are not missing something which is actionable and not doing $1 million workup, right? So that is first thing about the AFib, that could it be impacted by thyroid in this particular scenario? We are not seeing any other clear clue that this patient is septic, this patient has an infection going on, which could be causing AFib as a non-specific response. So once we have ruled out this impact, the third question becomes that is there a pressure issue distally to your right atria and right ventricle, which might be causing AFib in some way, right? So we know that how sometimes pulmonary artery pressures play a crucial role in genesis of AFib. And again, we don't know about when did this AFib start in this person. We don't have a past record. Who knows if this patient had intermittent runs of AFib even 2 months before versus is it really new onset this time in the admission? So that also changes the calculus that when did this AFib actually begin, right? But in general, like at least if the AFib is of new onset, then some people recommend that if there is like enough clues, you should entertain at one point the possibility of pulmonary artery being on the hook, either in the form of acute pulmonary embolism or chronically in the form of pulmonary hypertension or pulmonary arterial remodeling. So I would be wondering that could there be something wrong with the pulmonary artery as well, right? Once we move past that, then the final piece of the puzzle comes that why does the AFib happens? We know that AFib happens because of the abnormal atrial rhythms which are generated classically from the pulmonary veins, which is on the left atrial side. But sometimes it also translates to the right atrium being involved as well. And oftentimes, disproportionately, what happens is that in restrictive cardiomyopathies, as long as the ventricles are involved, probably atria are involved even more. That's why you might have heard if you read like random cases or textbooks that often people, let's say, who have amyloidosis, often they will say that the atria are massively dilated. And this is one of the reasons why atrial fibrillation is more common in certain kinds of cardiomyopathy because there are some cardiomyopathies which affects your atria more profoundly than the ventricles, right? So in this scenario, if we are not able to find a clear, concrete answer anywhere else, like thyroid is fine, no other drugs are there, pulmonary artery is fine, then you start wondering that what kind of myocardial process I am dealing with, which is causing the AFib, right? Now, of course, in older age, ischemia can be one of the reasons why you might have abnormal rhythms, but again, we are not getting that flavor, right? That this person has that angina chest pain and ischemia at the play. So we are assuming that maybe vessels are fine and something is wrong with the myocardium itself. So in the next aliquots, I will try to see that what's the picture which I'm getting for basic labs, which might clue me towards one of these sinister pathologies which might be affecting the atria. Rabi, what are your sense about this atrial fibrillation? Can we make any progress from that?
Your legacy in medicine, Kirtan, will be when you retire, which is the day you leave this earth is the same day you'll retire. I guarantee it. Your legacy will be to be so thorough and so comprehensive about everything. I think that my brain is wired differently than yours, which is why I love discussing with you, because my legacy will be try to make things boring and simple and silly. And so let me tell you what happens in my mind when I see a patient who is essentially anasarchic it's a stark it's actually picking up on where you left off with labs. So when I see patients with lower extremity edema, uh, just lower extremity edema, I know that I will be able to point with my one finger where the problem is. And what do I mean by that? I point at the venous valves for venous stasis. There is the problem. Or I point to the heart, there is the problem. Or I point to the kidneys, there is a problem. Or I point to the liver, there is the problem. It becomes much harder to point at one specific thing when the whole body is swollen. And this is where the labs are. And you can stratify your causes of peripheral edema into structural issues with the heart, with the kidneys, with the liver, with the venous valves, or you can be open to the possibility that this is the effect of a specific substance. And the specific substances involved are the ones you already mentioned, albumin, thyroid hormone, and then not uncommonly an exogenous medication like amlodipine or gabapentin. So I'm really intrigued by these labs because most of the time when your whole body is swollen up, it's not the effect of a specific structural issue alone. It's that you will find a substance. And that substance is very productive on lab tests. It's a deficiency in albumin or an accumulation of, it's a deficiency of albumin or a deficiency of thyroid hormone or the accumulation of an exogenous medication. So I'm very eager to hear these labs because when I see puffiness everywhere, I heavily invest in the albumin and the TSH. And you've already made another reason why the TSH might be important. But just to make a very simple learning point, when just two legs are swollen, it's often a structural issue. When the whole body is swollen, you have to be open to a substance, and you often find that substance either in the patient's pill box, amlodipine, gabapentin, had this yesterday actually, with pregabalin, or you find it in the blood work with two simple tests, albumin and TSH. So I think that it would be remiss not to get those tests in this patient at least at some point. Fahad reveals no clues. He's a poker player like no other. So, Fahad, mic to you.
So now I'm gonna give you the labs you guys have been asking for. So a complete blood count was done, which revealed her hemoglobin was 12.2, the platelets was elevated at 6.3. Otherwise, the CBC were within normal limits. A urine routine examination was also done, which was within normal limit, except that she had trace proteins in the urine, that is about 1 plus. As part of the routine workup, a renal function test was done, which revealed an elevated urea of 106 and an elevated creatinine of 1.6 milligram per deciliter. Now, I don't have a baseline creatinine. Her liver enzymes were within normal, and as Kirtan called it in the first discussion, her serum albumin was 1.9. Her complete metabolic panel was not remarkable. Further, a thyroid function test was also done. I don't have the exact values with me, but in total it revealed that she had an elevated TSH with decreased FT3 and FT4, slightly on the lower side. For them, I'm just going to give some of the imaging as well. Her chest X-ray showed she had cardiomegaly with otherwise normal lung fields. There is no signs of pleural diseases. Now, the $1 million investigation, which is the echocardiogram, it revealed that she had severe pulmonary artery hypertension with right atrial and right ventricular dilatation. Left ventricular systolic function was preserved with an ejection fraction of 55%, and there was no other regional wall motion abnormalities. Now, one thing I would like to add is that initially her hypothyroid, her thyroid status was attributed to toxicity of lithium, but as a part of a routine workup, an anti-TPO was done, which was elevated at 1,529 international units per milliliter. And I'm going to stop here.
Kirtan, I think this is such a juicy part of the case. May I propose a 4 or 5 minute breakout room for people to get their thoughts together and then we can learn from you? Is that okay?
Perfect. And Rabi, in fact, before we go, we can also clarify with Fahad one key point
Yes, yeah, of
that
course.
Fahad said that there were like trace protein in the urine. But Fahad, do we know if we were able to quantify like urine protein create ratio or 24-hour urine protein if you have that data?
I don't have the exact data, but as far as for what I believe is that it was within normal limits. The proteinuria was very trace.
Thank you.
Excellent. Excellent. Okay, we'll just do a 3 to 4 minute breakout room for you all to nerd out with each other. Then we'll come back and hear from Kirtan. All right, Dr. Patolia, what do you think?
Yeah, so very cool. And because of the sake of time, I will make it brief. Like I will touch on the important points that we are seeing that BUN is elevated, creatinine is elevated, but without having the baseline, it's hard to make sense of what is the intensity of this. But looks like BUN is more elevated than creatinine. Now that may not add too much to the value, but sometimes it's just about decongesting the patient and see what happens to the kidney side. Like if you can see that kidneys are improving rapidly, urine output is fine, then you might think that this was just pre-renal kind of congestion kind of stuff rather than the intrinsic kidney injury. And again, you can get a repeat UA, spin it nicely, quantify the protein again if you are suspicious something is wrong with the kidneys. So that's what I will say about kidneys because we don't have any other clues as of now. Then secondly, about this lithium being involved in the thyroid dysfunction. So classically, lithium is known to cause thyroiditis and it causes hyperthyroidism state in the acute phase. But Fiat Sim did the appropriate job that they were not sure that this hypothyroidism can be attributed to lithium alone. So now with the high TPO antibodies, it kind of feels like that maybe it was autoimmune pathology, which is not unusual. Like often thyroid pathology is autoimmune driven or not. And I'm trying to understand that should I link that with any other process in the body? Maybe there is another autoimmune process or another endocrine process at the play or not. I'm not sure yet. And that is where the low albumin comes into the picture, right? That unless we conclusively prove that it is getting lost from the urine, the question becomes that why your albumin is so low? Like we haven't heard the story that patient is malnourished, is alcoholic, like two common things which might cause low albumin. Then the question becomes, are we losing it somewhere in your stools, right? Like, does this person have some kind of protein losing enteropathy? And oftentimes, you may not have diarrhea as well. So it's hard to make sense of how much weight will you put on that. Will you investigate something in the GI tract or not? But I will definitely keep and watch on that because I don't have explanation for. And this albumin, I would say, is like pretty decently low, right? I mean, if albumin was 3.23, you don't make much out of it. But when it is less than 2, and kind of hypothesis which Rabi said earlier, that maybe there is a substance at the play when you see edema everywhere else, and now we have the proof of it. So you have to understand why this is important. And also the fact that patient was taking levothyroxine still didn't have appropriate levels. The question becomes, was it because of the absorption issues of levothyroxine, or was it because it was not dosed properly, right? So both those things I am considering, and hence the GI tract is something I will entertain. And then finally, the question becomes what to make with this pulmonary arterial hypertension, right? So initially we were saying that something is wrong with your thorax as such, like mediastinal structures, maybe that's why there is so much congestion. And from the echo which Fahad told us, there is no systolic dysfunction. Valves are looking fine. Pericardium is looking fine. And I didn't hear the diastolic dysfunction, but probably it is normal as well. So the question becomes that if the heart is doing okay, why you have severe pulmonary arterial hypertension? And we have to do the academic exercise to try to figure out that if we had to put this into bucket, which kind of pulmonary arterial hypertension this would be. Is this type 1 pulmonary hypertension, which is by far the most common and also the most, how to say, notorious because it's very severe in nature? And then you have to start wondering that why would this person have type 1 pulmonary arterial hypertension, right? And of all the risk factors which we have so far, only one thing I would mention is that, of course, we need more clarity. We need imaging of the chest to see what is there in the mediastinum. We need some like autoimmune serologies. But sometimes thyroid dysfunction, when it is long enough and when it is severe enough, is also known to cause pulmonary arterial hypertension. So if we don't see anything else, and we know thyroid is not a rare diagnosis, right? It's a common thing. So I would also keep in my mind that could the pulmonary arterial pressures be also impacted by the thyroid hormone dysfunction in this case or not? So that is where my mind is at right now. And let's see what Rabi has to say.
No, I'm right there with you. Kirtan, instead of finding one thing, we found three things: a low albumin, a low thyroid hormone level, and pulmonary hypertension. And how do we connect the dots? I think that, as you argued, I think the pulmonary hypertension can easily be a consequence of the thyroid disease. And so if you're trying to make a streamlined approach to this, you would put that aside. And the question is, how do you study the relationship between albumin and thyroid disease? And I think the interesting thing about albumin, as you mentioned, is that although albumin could be a deficiency of generating albumin, it's much more likely in a patient who is anasarchic, a loss situation. And there's no loss in the kidney. So is there loss in the GI tract, or much less commonly, is there diffuse loss in the vessels as part of a vascular leak syndrome? But just to be brief, the relationship between albumin and thyroid can be clarified by albumin as just part of many proteins that are lost in whatever losing process is going on. And one of the proteins that can be lost are all the thyroid binding hormones that keep our thyroid activity going, especially thyroid binding globulin. So there was a really cool case of nephrotic syndrome that I came across in which a patient who was on stable doses of levothyroxine developed nephrotic syndrome from another reason, then became profoundly hypothyroid simply because of the loss of a thyroid binding globulin in the urine. So I think compressed time is a beautiful thing because it forces you to try to be reflexive in your thought. My instinct is there's an albumin losing process. That albumin losing process is contributing to thyroid loss, and both of those things are acting synergistically to cause pulmonary hypertension. So for me, even though we have three leads, if I were to rely on instinct and the simplest way of connecting the dots, I think if we find out where we're losing albumin, either in the kidney in a sneaky way that we need a urine protein to creatinine ratio to clarify, or more likely in the GI tract, or least likely as part of a diffuse vascular leak process, I think we can subsequently explain why the patient is hypothyroid despite taking her medications. And I think we can subsequently explain the pulmonary hypertension from the thyroid disease. So like you, I think I am most interested in studying where is our albumin going. All right, Fahad, mic to you.
All right. So, as Kirtan said, in view of severe pulmonary arterial hypertension and the presence of an autoimmune thyroid disorder in a female, we had to consider the possibility of connective tissue diseases. Hence, an ANA profile was done, which were within normal limits, and further complement levels was also done, which was also within normal limits. And now, further, a high resolution CT of thorax was performed, and the scan revealed that she had minimal bilateral pleural effusion, minimal pericardial effusion, and moderate ascites. No significant findings towards interstitial lung disease, pulmonary embolism, or any parenchymal abnormalities were noted. I'm going to stop here.
Yeah, I'll just reflexively share thoughts because I see what you have left. I think, or what you said with instinct alone, is that this is likely class 1 pulmonary hypertension. has been taken to another level of certainty because we see that there's no left-sided heart failure impacting the lungs, and there is no intrinsic lung disease. So I think this additional data helps us zero in on the likelihood that the source of her pulmonary hypertension is within her pulmonary artery. What do you think?
You're right, Ravi. And now we are left with figuring out that how we would link that with what is going on in terms of our albumin, and we haven't figured out yet, right? So I think again, reflexively, I would say that we would get urine protein create ratio, we would get 24-hour urine protein just to be on the safe side. And again, to move the case forward, like maybe not in the ideal world, but since this patient is old enough, has some degree of kidney dysfunction, maybe something wrong with the heart, you are not sure, maybe some capillary leak, fluid overload, right? So always wise to get like SPAP immunofixation, making sure the M protein is not at play, because we know that multiple myeloma amyloidosis can impact your capillaries, your cardiovascular system in weird ways. And there are various syndromes which connects the endocrinopathy and capillary leak as well. So I think getting SPAP immunofixation is reasonable. And then another point I would make is that when you have severe pulmonary arterial hypertension, kind of like this, type 1, we will get the right heart cath to figure out how bad it is. But oftentimes, one of the ways in which you can occultly lose albumin is through the intestine by the lymphatic dilatation, so-called like intestinal lymphangiectasia kind of stuff, that there is so much pressure going on that the lymphatics in your intestine become so dilated that they are so leaky that you start losing the protein. So, and again, this is a rare hypothesis, right? So you should always entertain this once you have conclusively and exhaustively ruled out the protein-losing protein-losing nephropathy as such. So I'm wondering that maybe that could be a unifying process, because that would be able to explain that why albumin is so low without any other conclusive evidence, right, Ravi? Is that a fair thing, probably?
I think the exercise that you're doing so well is you have three things. This case is giving you so much to work with. You're not struggling to figure out an explanation. We're struggling with too many explanations, right? And so this is a really wonderful exercise to try to see how do these things link. And I think we have focused on understanding the localization of her pulmonary hypertension because the lungs are spared and the left heart seems to be spared. It's class 1. Um, we haven't made progress on understanding why she's hypothyroid, and we haven't yet made progress um, on her albumin loss. And I think being able to make progress on her albumin loss will be very, very illuminating. Um, but statistically speaking, it's in the GI tract. And so I think if we are able to see why she is hypoalbuminemic, I think this case will become much easier to solve. But I think you're making a very powerful uh, connection here, which is you may not need any more information to put this case together if you assume she has protein losing enteropathy, because protein losing enteropathy is a very well described a consequence of severe elevated right-sided pressures. I think it's best described in pericardial disease, but I find it to be just as plausible in pulmonary arterial disease, where the pressures in her RA and her IVC are so high that she's leaking fluid into her belly. They may be so high that they're congesting her gastrointestinal lymphatics, as you just said, resulting in protein-losing enteropathy. So if you're trying to connect all these things, it's so easy to see severe pulmonary hypertension resulting in lymphangiectasia and protein-losing enteropathy from the GI tract. And then the protein-losing enteropathy is a reminder that all proteins are lost, contributing to her thyroid disease. So it's interesting to know, where does this case begin? Does it begin with a case of pulmonary hypertension that skews her albumin and thyroid disease by protein-losing enteropathy? In which case we have to figure out, well, what's driving the underlying pulmonary hypertension to begin with? Or is this a case of thyroid disease that is very well described to cause pulmonary hypertension, and the pulmonary hypertension is not the root cause? And so I'm struggling with this, how to make this, but I think, how do you make progress? You really have to understand where her albumin is coming from. But yeah, a struggle of great joy, that's for sure. All right, Fahad, I think you have us on the edge of our seats.
Yeah, so I just want to emphasize yet again how epic this discussion is. But for the sake of giving another lab value, I'm just going to say out that all the problems that we have discussed so far, like hypoalbuminemia, pulmonary hypertension, there are various evidences in the literature which makes lithium the culprit in all of this. That is long-term lithium use. And as our patient had a lithium history of about 30 years, we had to suspect lithium toxicity in this case. So that is, I'm just giving you a sense of where the diagnosis was going towards, and hence a blood lithium levels was done, which came back within normal limit to our surprise. That is about 0.6 units. Now, later, the patient was discharged because of financial constraints, and she represented a year later with the same symptoms, with the same, almost the same lab values as well, but in a worsening manner. And this time, another echo was repeated. I'm just going to pull up the echocardiogram. So take it away.
You've caught us red-handed, huh, Kirtan? I have no idea how to interpret this. And I'm hoping that,
Yeah.
what I see is a tibial plateau fracture, Kirtan. What do you see?
No, I mean, I want Fahad's help as well, but I mean, looks like walls are maybe a little bit thick. Maybe there's some pericardial fluid. That's all I can say.
Yeah, yeah. I see maybe a small amount of pericardial fluid, and I see a thick myocardium. But unfortunately, these are just instincts. I'm no different than somebody who's just beginning to read these echoes.
Yeah, Fahad, please enlighten us that what was the official read. Yeah.
Pretty please, Fahad. We're desperate. This is perfect, Kirtan. I think Fahad is frozen to further our embarrassment and shame.
Here you go. Can you see another one? Just one sec. Let me share it again. Yeah, I hope it's visible. Any thoughts?
Rabi, mic is all yours.
Yeah, well, good thing I can read. I think this has enlarged atria and some speckled calcification is my official read. What about you, Kirtan?
No, I agree with you. I want to hear from Fahad that what was there is official presentation.
Yes, so this was the official read. And again, I'm not good at reading this either. So what do you guys think about the characteristic of speckled calcification? And does it point you towards a particular diagnosis as such?
Yeah, Fahad, that's a valid point. And as you were kind of hinting us towards earlier, and I also like at one point I was thinking that okay, there is lithium, and usually lithium is known to cause rhythmic effects. It's not well known to cause cardiomyopathy as such, but like it's you could imagine that these drugs are so rare, it might end up causing some degree of changes in the pulmonary arteries or maybe in the heart as well. So lithium cardiotoxicity and lithium induced side effects make sense. And also the lithium levels doesn't help much because lithium levels are more helpful in acute toxicity. In chronic toxicities, sometimes the lithium levels might be normal as well. But again, like you have to take everything together. Kind of like Rabi was saying, right? That do we have enough explanation for all of them? And we still haven't understand where the albumin is getting lost, right? And final point I would make is that I'm not sure about the speckled calcification as such, but we know that the speckled pattern is something which has been well described with amyloidosis as such, like classically AL amyloid and TTR amyloid. And that was probably one of the reasons why we were wondering if we should get the M protein and SPEP ahead of time. But I'm not sure whether speckled pattern versus speckled calcification is like two different things. And especially, I don't see any ESRD, any calcium metabolism disorders, which might cause like calcification as such. So I'm not sure. Maybe I can ask Rabi that what's his sense of this speckled calcification?
Yeah, Kirtan, I can make no more progress than you did, but I think what I'm getting clarity on is the sequence of pathology. When you see intrinsic disease in the heart more and more and more, it's easy to see that if you figure that out, you might subsequently explain the consequences on the GI tract, through venous hypertension and lymphatic hypertension and protein-losing enteropathy and thyroid loss. So the only progress that I've made with just hearing that when you put an echo, you see that the heart itself is more and more and more and more unhappy. You realize, I think, that the sequence of events will be clarified by understanding what's wrong with the heart. And to that, I have nothing further than what you just said. So, cardiac causing protein losing enteropathy has become even more suspicious for me.
So yes, Vai, please take us home.
Yes. So as the repeat echocardiogram revealed an enlarged atria, also another finding I forgot to mention was that there was a phenomenon called atrial standstill in the video of the echocardiogram, and the spectral calcification, as like many in the chat and as you guys emphasized, is suggestive of amyloidosis. So the next step was to confirm amyloidosis, and I'm just gonna pull up some more pictures.
Oh, by the way, Fahad, I did notice the atrial standstill with my excellent echo skills. It was very obvious, quite frankly.
Way to flex things, Ravi.
Oh, I'm just joking. I'm joking because the
I
picture.
know. I'm just joking as well. The way you are flexing.
I say that because it was a picture, Kirtan, and there was no video. So very obvious atrial standstill. Oh my gosh, what a
So I hope it's visible. It's visible, right?
Yes.
yes.
Yes, Vai, you can scroll down,
Yes.
I guess.
So an abdominal fat pad biopsy was done, and this is the extracellular amorphous eosinophilic granular deposit that we hear from pathologists. And this was further stained with Congo red, which came back positive, indicating towards amyloid. And further, this is the characteristic apple grain birefringence in polarizing microscopy. So the final diagnosis was amyloidosis with restrictive cardiomyopathy, SNO dysfunction, and type 2 cardiorenal syndrome, and she had severe pulmonary artery hypertension, which is secondary to restrictive cardiomyopathy as well. Now, I'm just going to give you a little glimpse about the management of this patient. As this was caught at a very late stage, she was treated for diastolic heart failure, but ultimately she did succumb to her disease. So further evaluations with bone marrow, the protein evaluation, we were not able to. So that was the case.
Perfect. Wow, fine. The way you presented the streamlined journey, and also like to recap our journey, like we were like what Rabi was saying initially, that where is the process, like because of the low voltage, is it in the myocardium, is it in the pericardial space, or is it in both of them, right? And then we were initially saying that usually heart failure does not affect upper extremity, but then we were thinking that there are certain unique forms of cardiomyopathy which might do it, right? And which might affect the low albumin as well. And then we got more and more evidence that problem is in the heart itself. And then at one point we were wondering that should we just get aspect, fixation because of the ways how amyloid and M protein can interact with the capillary leak and low albumin in various ways, right? And I think with the progressive echocardiogram showing worsening and worsening, we found this pathology. And in fact, like I would say that although like the lymphatic systems being involved and losing protein through the GI system is an elegant way, but another possibility sometimes which can make sense is that maybe you have amyloid in your intestinal wall itself, and we know that the intestinal amyloid is very notorious, like it doesn't present with the classic symptoms which you expect, and unless you do a Congo red on your intestine, you will never find out if there was amyloid in the intestine, right? So many amyloidosis of the intestine goes unrecognized because we don't pursue imaging and we don't pursue the biopsy always. So that is another way to tie all of this together. And maybe like the pulmonary arterial part is the part which is little bit kind of like difficult to grapple with, that why it was so severe initially itself. So kind of like what Ravi was saying, right? That maybe it's like perfect storm, that maybe thyroid was contributing to some extent, maybe lithium was implicated. And on top of that, the diastolic dysfunction of heart probably was not helping either. So it makes sense. Everything makes sense now. What do you think, Ravi? Any things to add to this analysis as such?
Very hard to do to add, Kirtan. I think that there's a lot to reflect on here. I think the first, just one clarifying question for Fahad, is we know this is amyloidosis. So our common options are light chain amyloidosis or transthyretin amyloidosis, which would be clarified in a couple of ways. Do you happen to know the nature of the amyloid deposition here? I'm sorry if I missed it.
No, I'm not actually sure about the
Okay.
nature, but again, we
Okay.
were not able to do further
Right.
testing
Right.
to
Right. Right.
clarify it. Yeah.
Right. Yeah. I think that the way you would clarify what kind of amyloid it is you can do light microscopy and mass spectroscopy to understand what protein is it that is misfolding. And I think the likely scenario in a 58-year-old woman is unfortunately she likely has AL amyloidosis, I would guess, because transthyretin is either age-related wild-type disease or congenitally mutated. And so her two options, realistically speaking, are she has light chain amyloidosis or she has hereditary ATTR. And hereditary ATTR would less likely have such a systemic fingerprint in the absence of neurological symptoms. Going back to her platelet count, I think it's very plausible that she might have some splenic infiltrative involvement, which can essentially remove the spleen from functional circulation. So, yeah, I would worry that she has light chain disease based on how severe this issue is. And so, if we just assume that for a moment, um, how does this case unravel? And I think it unravels just exactly as Kirtan says. She has systemic amyloid deposition in all the organs we were implicating. Um, and so the question is, what about the pulmonary hypertension? And I think it goes to show you how difficult it is to really localize pulmonary hypertension with a high degree of fidelity, Kirtan. I think if we perhaps go back to that exercise we were trying to do with the EKG to say, is this EKG in the context of heart failure telling us of a pericardial disease or a myocardial disease? Pericardial disease and pulmonary hypertension are both examples of obstructive diseases, which tend to present with much more hemodynamic consequences, tachycardia, hypotension, dizziness, than they do venous hypertension. And so the fact that she had so much venous hypertension, I think, was a clue to a myocardial hypothesis. And the question is, how do we link in the pulmonary hypertension? And I think it goes to show you that when we look for left-sided disease as a cause of group 2 pulmonary arterial hypertension, it's much harder to detect left-sided heart disease that isn't dilated cardiomyopathy. And the way we see this most commonly is occult left-sided disease in patients who have the more garden variety versions of heart failure with preserved ejection fraction. And the spectrum of metabolic disease, where we put a probe on them, we see that their echo on the left side is not too dramatic, and so we attribute their pulmonary hypertension either to OSA or obesity hypomyelination syndrome, underemphasizing the contribution of an unhappy left ventricle. And I've seen this play out before where you're imagining what this patient's disease is infiltration of her left ventricle, and that may not be macroscopically evident on a transthoracic echo. So I suspect that she didn't have class 1 pulmonary hypertension all along, and that she might have had severe left-sided heart failure that was presenting in such a sneaky way. I'm curious what your take or analysis is on that, Kirtan.
So no, I mean, you are right that it's very hard to make sense of without getting right at cath, and we know that sometimes there is both, right? Like combined pre and post capillary. So it's like very hard to make assumption. But I think you are right that one point which we did comment initially was that which kind of infiltrative cardiac processes disproportionately affects your atria, because we were thinking that where is this AFib coming from? And if you just randomly look at the infiltrative cardiomyopathies which causes atrial arrhythmias in the index presentation, then amyloidosis take the tops the list, right? And on conjunction with the sinus process, some conduction issues, right? And also the fact that there was atrial standstill, the fact that atria was massively dilated, again points to the fact that how these forms of cardiomyopathy perfectly impacts your atria even more so than it does ventricles, right? So it's possible that this person had atrial dysfunction ahead of time of ventricular dysfunction, and maybe that's why we are not able to link it to the pulmonary artery pressures at that time. So yeah, that's my assumption. What do you think, Ravi?
Sorry, right there with you, my friend. I think that's very, very wise. Oh, we have taken up so much of everybody's time. I mean, Fahad, I'm curious what your reflections are of this one believable case, and then we can hear from Aaron.
Yes, so the discussion was on point, and I want to emphasize on something the discussion failed to grasp it. That is, initially her echocardiogram was completely normal, but when she was presented about 3 months after the initial presentation, her echo showed this. So again, in a short span of time, I don't think there will be such a large amount of deposition. So the reason for that is when we do a normal echocardiogram, what I learned from radiology is that from cardiology is that when we do a normal echocardiogram, we are more prone to miss the things that are happening in the myocardium. So instead, we have to do an echocardiogram with dynamic characterization, something of that sort. So it is always best to ask what you're looking for. And that is all I have about the case. Thank you guys for this amazing discussion.
I can see why you've been waiting a while to share this incredible experience, Fahad. I don't want to talk babble too much. I'm reflecting on so many elements of it. We're very, very grateful. All right, Mike to you, Aaron.
Yeah, thanks for that great case, Fahad, and great discussion, Rabih and Kirtan. I know it's like 17 minutes past time, so I'll just share one of the teaching points. So this patient initially presented with diffuse edema to both the upper extremities and the lower extremities. So one of the teaching points that Robbie mentioned is that swelling, especially in heart failure, is related to how much above baseline the venous pressure is elevated compared to the absorptive capacity of that part of the body. And especially in our lower extremities, this is more expected due to the fact that there's gravitational forces at play and less likely in the upper extremities due to the constant use and just the decreased amount of pressure needed to absorb fluid in the arms. So yeah, especially in patients with anasarca, we have to consider structural issues, including valves, the heart, the kidney, and liver versus substances like albumin, thyroid, and other exogenous toxins or drugs. So yeah, thank you for this wonderful case, Fahad.
Thank you, Aaron. I appreciate your emotional intelligence. Brains are fried from such a complex case. I'm not surprised with Fahad and Kirtan here. Final words to you, Kirtan?
Oh, all good. Well, thank you, Fahad, for presenting this case in the way you presented to maximize the learning. And of course, thanks to Rabi for all the insights. Looking forward to more sessions in the future. Thank you.